So when I turn to disparities in ESRD and dialysis, which have been touched on a little bit, and I won't go through the nitty-gritty of this slide, but just to say that this is very similar to what we looked at a moment ago when we were looking at rates of albuminuria, or the protein in the urine. To say that when we looked at groups of, here, the team that looked at this, when they divided up African American men and women compared to white men and women who had, had diabetes, didn't have diabetes, had hypertension, didn't have it, had the combination, didn't have the combination. No matter how they sliced the population, the rates of developing end-stage renal disease were higher among African Americans. So it is not explained by rates of diabetes or hypertension. Okay. So with respect to income level, this was a study now from 22 years ago that was it was the earliest study really to look at this differential association between income level and race, and then risk of developing end-stage renal disease. The major take-home message here, again, is that this steep sort of association between income level and the chances of developing kidney failure, it's much steeper among the black patients, which they're represented in the group that has the boxes there as the on the bar. And so this has been looked at more recently by a group that's based in Atlanta. And what they were looking at here was they were looking at neighborhood levels of poverty. So instead of kind of knowing how much money an individual earned in an individual family was earning, they were looking at rates of the sort of the proportion of individuals living in a community, living in a neighborhood, who had an annual household income that was at or below the federal poverty level. So the federal poverty level, particularly around the time of this study, was about $25,000 for a family of 4. So if a family hits that or beneath, they would be considered to be living in poverty. So they were looking here at, in the neighborhood, there was about 5% or less who lived in poverty, all the way up to 25% or more who lived in poverty in the neighborhood. Major message from this is that that's where you see the greatest difference between the blacks and the whites in terms of rates of kidney failure. Okay, is when we're in communities that have very high rates of poverty. And so, kind of to hammer this point home a little bit more, we were really interested in, is it just, where people live, or is it also kind of what's surrounding where they live? So meaning, is it, we sort of hypothesized that if a person is living in a community that is that's poor, that's impoverished, but is surrounded by wealthier communities, could some of the resources in those wealthier communities maybe filter into that poor community, making that person's risk, in this case of kidney disease, a little bit less than maybe someone who lives in a community that's impoverished, that's surrounded by other impoverished communities. And so we did, find a suggestion of that, meaning that, there's sort of a trend here where those that lived in, communities, these sort of high outliers, those that lived in the communities that had, tons of other communities surrounding them that were also impoverished, did have slightly higher rates of developing kidney failure. I want to turn a bit, this point was made earlier, I want to turn a bit to this issue of late referrals. Now, Dr. Swanson was talking about referral to transplantation. Here I'm speaking about referral to see a nephrologist, which has been mentioned a bit. So in general, blacks are actually more likely to receive late referrals. They are referred later in the course of kidney disease to see a nephrologist than are whites. That's the basic message of this slide. Now, why does it matter? Well, late referrals to a nephrologist actually result in worse outcomes, and particularly among blacks, right? So it's bad for everyone. So if you look, so for whites, those that were referred late had a 50% greater risk of dying. This is after they had started dialysis in this case. But for blacks, if they were referred late, they had an almost 7 times greater risk of dying. So that's a big issue. And then this is a recent study that I found very noteworthy in that essentially, so in communities in America, there are, so in general, let me actually just sort of trace through the far right-hand side of the slide here. What it's reflecting there is the proportion of the U.S. population that has been that lives in poverty. So they looked at 1995 to 2004, and there was 10.9% of the U.S. population living in neighborhoods or communities that had high levels of poverty. And then in more recent years, it's 12.5%. So that number has increased slightly. But when we look at the population that is beginning dialysis, right, in that older time period, 20 years ago, 27.5% or so came from communities that were impoverished. But now 34% are coming from communities that are impoverished. So it sort of gets at, some of the challenges, many of the challenges that our patient population is facing today. And so those of you who are nephrologists in the room, we should have like a secret handshake or something. Okay, so, or a wave. So for the nephrologists in the room, I'm sure are likely aware that for years, the data has suggested or shown us that African Americans who are treated with dialysis have better survival than white patients, right? So meaning if you took all African American patients in the United States, you took all white patients in the United States, and you follow them over time, several studies have shown us that African Americans live longer. So that notion has been challenged recently in a couple of studies. I'm showing one of them that I was fortunate to be involved in, and letting us know that survival advantage, if you will, is not true for every age group. So for older populations, that's true. So for people over 50, it appears that African American patients on dialysis do tend to survive longer than white patients who are on dialysis. Now, our transplant colleagues will say that it's sort of confounded by the lower rates of transplantation among African Americans, and so people who would have otherwise have been transplanted if they were white are staying on dialysis, and so forth. We can have that conversation later today if you'd like. But when we do look at the younger population, people who are under 50, what we see is that for young patients, African Americans actually have poorer survival than do white patients. And what we found in this study is that seems to be largely accounted for by differences in socioeconomic status. So for the group, you see that orange line there, for the lower socioeconomic status black patients, and again, they're young dialysis patients, they had a particularly poor survival compared to the other groups. So that finding of this better survival is complex, and should not lead anyone to think that transplantation is not the best treatment for patients with end-stage kidney disease, because it trumps all of what I'm showing you here in terms of rates of mortality. Transplantation is better than any of these dialysis findings. So to summarize this section, so compared to whites, racial and ethnic minorities are more likely to develop end-stage renal disease. They're referred later to nephrology, generally more likely to survive on dialysis, although that's not true among younger adults. And then finally, these disparities may be strongly influenced by socioeconomic factors. Turning to transplant. I apologize, this slide got moved a bit. So so it's been known for a while now that when we compare, here we're comparing again African Americans to whites, there are fairly equal rates of patients who have advanced kidney disease and are of either race, there are pretty equal rates of them being medically suitable and interested in going on to get a transplant. This is in green, those are whites, and in red, it's African Americans. But then as we move through the steps of the transplant process, particularly when we get now to the wait list and the actual receipt of transplantation, that's when we start to see these disparities, okay, in terms of where whites are going to be more likely, African Americans less likely. So why is that? I found this study very interesting recently that was looking at, they were looking at rates of living kidney donation across race and also across level of household income. And whereas it's been known for a while now that certainly rates of living kidney donation are lower among African Americans for a number of complex reasons, in this study, what they found is that at the highest levels, when they took people who kind of had a pretty high income at the highest level, they're at quartile 5, that actually the black living donors were more likely to donate. And so the message, more likely than whites. And so the message from this study was that, again, financial sort of pressures may be the real barrier to African Americans who may want to donate a kidney, that it's less about cultural this and religious that and all the sort of things that you all have heard about, and more about pocketbook issues, you know, like it's concern about whether they're going to be able to afford to take time off from work and so forth. And so I think there's a real opportunity here. And so again, as I mentioned, transplantation, absolutely the best treatment regardless of the patient's race. And what in our group we recently looked at, this is a paper published in Jason for the nephrologists in the room. What we looked at recently was rates of deceased donor kidneys and their survival over time. And what we basically found was that the rates of survival have improved for all patients, with greater kind of improvements for black patients than we've seen for white patients even. And the disparities in outcomes as far as the survival of these grafts are actually narrowing in recent years, which is very encouraging. So summary again for this section. So compared to whites, racial and ethnic minorities are equally as interested in being transplanted, but are less likely to complete the steps towards transplantation and less likely to receive living donor transplants. Disparities in the receipt of live donors may, again, be strongly influenced by socioeconomic factors, and racial disparities following transplant are actually narrowing. Okay, so why? So this is a large, and I'm not going through this whole thing, don't worry. This is a large conceptual framework for thinking about social determinants of these disadvantages and kidney disease. And I'll just mention the three sort of big baskets, everything from residential issues and residential segregation and all of the factors that kind of flow from that, discrimination and kind of the stress that it can play in individual patients in that situation, and then insurance status and the role that it plays. And these can all ultimately lead to kidney disease, progression of kidney disease, and then ultimately mortality. I am going to focus on one of these, and that's poor nutrition.